more detailed understanding of the scoring and regulation of the scoring. So this is really a tool for clinical practice. That's why we've got a one-day training, and we just show how we really utilize this for guiding our clinical work. We have a model of practice that we'll talk about in a little while. We particularly use, but there are, kind of multiple ways of working with attachment, as people would be aware. So the AAI remains the gold standard. There are other ways of measuring. So the one-day training is really oriented towards summarising the core purpose and structure of the AAI and its relevance in clinical and applied psychological settings. It's really good at being able to identify and differentiate the four primary AAI classifications. So secure attachment, dismissing, preoccupied, and what's described as cannot classify, and then unresolved. It demonstrates competence in administering and following a structured questioning protocol. So we go through just the delivery of the AAI tool itself and how to do that. And if you're working with clients, some clinicians, find it better to have someone administer the tool separately. Other clinicians will administer it themselves, but it's really important that we understand, and that the client understands that it's a very, very structured way of having an interview. So if you've already have a therapeutic relationship with them, then going through this interview process will be quite an unusual and different experience for them, because you have to follow the protocols and the methodology of asking the questions in a particular way and probing in a particular way. We want to identify the potential ethical considerations when conducting an AAI, informed consent, interviewee distress, and also the limits of interpretation. So, often when we go into, anything to do with memory, as people would be aware, we run the risk of triggering unresolved emotional issues from childhood and adolescence. So it's really important in, kind of administering the interview that you're able to slow down, but it becomes very, very important not to engage therapeutically. So if you know that the client, is highly reactive, highly distressed, you might want to do some real kind of practical setting up for the AAI if it's still clinically appropriate to run it, and also allow time at the end to return to more of a counselling therapeutic relationship with the client, but once you've gathered the data. And in the training, we do some analysis of AAI transcripts just to show what we're actually looking for when we're doing an assessment. We use the AAI classifications to inform preliminary case conceptualization. So, the findings from the AAI can really help us inform, how we're assessing the person's presentation. And then, of course, we want to demonstrate a degree of proficiency in summarising the findings in notes and reports or discussions, so that we're doing such in a concise way. So the AAI one-day training really focuses on the application of this tool in clinical settings. It doesn't engage with detailed scoring, so there's a whole numerical system that goes with the AAI, and that's more linked to the research side of things, and it requires the full training for the AAI is a 2-week intensive seminar, and then a 2-year follow-up scoring assessment. So, and the scoring, requires, something like 30 to 40 transcripts that are scored to an 80% accuracy across 2 years. So it's quite a big commitment to get to the level of scoring proficiency in the tool, which is what, as I said, a one-day training really can't get you anywhere. There, if you're that keen on wanting to really get the scoring, then you best go through the Mary Main's program with that. And it doesn't. So we're not looking at research outcomes. So a one day introduction to the AAI can show you how to utilize it for clinical efficacy, but will certainly not provide enough for any kind of research or publication efficacy for research. I just want to make that very clear that we're not, kind of trying to suggest that a 2-year program can be shortened into a single day. This is more how we've been using this to help guide our clinical work. So attachment itself is a survival-based bond between infant and caregiver. And there's these patterns are deeply established. They're neurological. They're not patterns that are based on language or learning. They're very much body-based patterns established between the 8 and 20-month stage life. So really very much driven by limbic brain organization, very much about affective regulation, about how a baby feels, what Bateman and Fonagy in their mentalization-based therapy would describe as epistemic trust. The feeling that inside the body that the child is safe. What human brains are endlessly seeking is predictability. That's what gives us our capacity to structure and plan. And so attachment is about a body-based predictability. So we'll have secure attachment or one of the insecure variants of predictability. Attachment creates a layer of regulation, which eventually, if the adults are sufficiently skilled, and as Winnicott would say, good enough parenting is what we're aiming for, not perfect parenting. So if the parenting is good enough to provide a pattern of security, then the child starts to develop down-regulatory capacity. If the attachment skills of the adult parent are not able to achieve that, then the child adapts in various ways. There's something like a 75% correspondence between an infant's strange situation outcomes and parents' AAI outcomes. The infant strange situation refers to the work of Mary Ainsworth. So people probably familiar with the chronology or the lineage story here, but John Bowlby introduces the idea of attachment into his work in London after the Second World War, where children were returning from having been billeted out from London during the bombings, and they were sent to various sort of places around England. And they were often their parental bonds were broken because the children were sent and the parents would stay to kind of work in the city. And with the end of the war, it was assumed that there'd be all these wonderful family reunions and kind of there'd be a lot of reparation. And what was discovered instead was that a lot of the children that returned were growing up with antisocial orientations, and that was Bowlby's first research program into studying delinquent children who were struggling after family separation during the war. Bowlby met Mary Ainsworth, who's an American researcher, and Ainsworth really started to develop a strong research protocol around attachment, which she called the infant strange situation, that she developed specifically for children. And it's an observational protocol where a mother and a child are brought into a room, and the child's observed. The mother leaves, and the researcher remains. The mother then returns, and so the way that the child responds to the mother's coming and going is really what's assessed in the strange situation. Some children become very distressed. Some children just really shut down. So this gives a kind of our first classification system around um, around attachment. So there's been a major study in Melbourne in recent years as well, but 75% correspondence between infant strange situation and parental AAI outcomes is suggesting that there's an intergenerational transfer of attachment disturbance. Um, different figures for insecure attachment in the population, but 48.4 is a relatively modest assessment of the extent of attachment disturbance. And attachment disturbance is linked to adult psychological disorders such as depression, anxiety, and at the more extreme levels to personality disorders, because these babies are growing into children, into teenagers, into adults who are adapting to an absence of something in their developmental history. And the AAI is just a really good tool for getting a detailed kind of landscape of what's happening in that adult's mind in relation to developmental experiences.
Excuse me, Nigel.
Yeah.
Have you noticed in the studies that within a family that the siblings, like the children, are likely to have similar um, attachment styles? Or is it?
Not necessarily.
Mm,
Um, it depends. So like at the level of extremity, when it's high levels of abuse or neglect,
mm,
you've got a likelihood there of disorganization occurring.
yeah.
But it's all Jerome Kagan's work on temperament.
Hmm.
That about a third of children are born more sensitive.
Hmm.
It just means that their central nervous systems are more active and reactive. So, there are different personality features that come through. So it's not uncommon for parents to treat three children the same way and one of them to have an attachment disturbance.
Mm, mm.
What it means, it's not, kind of anything kind of pathological in the child. What it means is that the parents were not able to pick the difference in needs in their children and to meet those needs. That it means more likely the parents had a particular pattern of dealing with the children that they applied kind of uniformly, but only one or two of the children responded, adversely to it.
Yep. Thank you. That's really interesting.
Um, so attachments measured, as I've said, through Mary Ainsworth developed the strange situation protocol to measure in children. And then Mary Main came along a little later and developed the adult attachment interview to assess attachment in adults. Now they worked together. They both worked with Bowlby. Um, Mary Main has collaborated with a lot of other people. Carol George has gone on to develop an assessment tool and treatment protocols. Um, Patricia Crittenden famously has also done a similar kind of modelling. So the AAI and this model isn't the only one out there. It's just one that we've used with great effect. Notice also that there's different nomenclature in children's research and adult research, which can lead to a little bit of confusion. we describe in the children's literature, there's avoidant attachment, anxious avoidant attachment. In the adult, it's described as preoccupied attachment and dismissing attachment and disorganized attachment. This is just an unfortunate historical situation which can lead to a little bit of confusion in the adult literature, but they're basically coterminous. They just come from different research protocols. So Carol George's uses a projected picture system to be able to determine and assess attachment style. Crittenden's is the dynamic maturation model, and that has a lot more kind of nuance and detail in outcome than the AAI. Peter Fonagy's reflective functioning scale course is a well utilized one, and Peter Fonagy worked with Mary Main and came out of her research work, and he was particularly interested in something that Mary Main introduced into the AAI called metacognitive monitoring. And that metacognitive monitoring is the first kind of introduction into this stream of research of a nature of the organisation of mind, which in the treatment protocols that we use, which are drawn from the work of Daniel P. Brown and David Elliott, metacognition becomes a very important feature in the way that we work with attachment repair. But Peter Fonagy developed reflective functioning in their model, the mentalisation-based therapy model that's been developed at the Anna Freud Centre in London. And it's picking up on metacognitive monitoring, and it's really a way of assessing how the person experiences their own mind working. Because the more ruptured someone's attachment system is, the less capacity they generally exhibit for higher level metacognitive tools like observing mind of self, mind of other. That becomes quite problematic with attachment disturbance. The ECR in various forms is a tick and flick that doesn't match very well in predictability, and it's not a particularly robust tool, but it's a great way of getting a bit of a thumbnail sketch. A friend of mine who's set up the Attachment Project website has collected a couple of million responses to the ECR. So some interesting information that they'll be publishing at some point. But the AAI is the most detailed, in my opinion anyway, and certainly gives the most information about organisation of mind. 2-year training, as I said, to do the full thing. But if you have a way of working with attachment and you're interested in just really kind of getting a bit of a landscape of your clients, then this tool can be quite useful from a clinical perspective. The AAI is really about generating a detailed description of attachment-related childhood experiences. So one of the terms that's used is it's a way of tricking the mind into rendering up its primary organisation, because the initial questions are about historical events, and then we kind of weave through and really start to try to trigger and elicit the patterns of language that have been set up in these early years of life. So, we're looking for coherence and consistency and productivity. Eric Hess, who's Mary Main's partner, described the AAI as an interview-based method of classifying a parent's state of mind with respect to attachment. And we've used it through, for particular utility through what we call the 3 pillars model. 3 pillars model that Brown and Elliott developed, and we've gone on to extend in some of our trainings and our practice. Pillar 1 is collaboration, creating a clear, overt relationship with a client based on mutual understanding and mutual agreement. So collaboration is really in a very overt process, a very conscious process. And metacognition then is the orientation of view, where you view your mind from, how you can see the operation of your mind and mind of other, how you can see the development of your mind from series of developmental patterns. That's the metacognitive component. And pillar three, the model that the model that we use is to identify the attachment style, to invite the adult to relax and to invoke a sense of themselves as a 5, 6, 7 year old, and to imagine ideal parents who invoke these qualities that of secure attachment. Um, we've found it quite a powerful tool. It obviously doesn't work for everyone, but when it does work, it can be a very, very effective way. We're not suggesting in this method that we're creating new memories. It's not a kind of a false memory generating tool. We're making it very clear that we're using the imagination to elicit experiences that create the neural circuitry that didn't occur due to attachment disturbance. So when we administer the AAI, we've got a 20 question structure. Administration, you need to leave between 45 and 90 minutes. So generally what I recommend to people is that they have a 2 hour block. And that allows then a minimum of 30 minutes to just reorient and reorganize, particularly if you've got a prior relationship with the person being interviewed. But even if not, if you're just doing it as an independent interview, it's important to kind of create some time for the person to move out of that kind of memory retrieval process and back into the here and now before they leave the office. It's interesting, someone with a dismissing attachment style will take more like 45 minutes. Someone with a preoccupied style will often take more, up to 90 minutes. I've not gone beyond about 90 myself. Really important to follow the structure with any kind of structured interview protocol. Its utility is based on consistency of application. And so following the question structures is really important. There's some expanding questions, some deepening questions, but this is one of the difficult parts of delivering the model. You've really got to restrain from any therapeutic conjecture or support or kind of, asking people how they are, or other than, are you okay to continue? Would you like to take a break? Of course, you want to apply, basic empathetic skills to the application, but we don't want to sort of confuse by, if we start becoming more therapeutic, then what we're doing is we're bringing the memory out into the present, and so we'll be interfering with the way the person's retrieving the information. So it can be difficult, as I said, when you've got an established relationship. And then what happens, we record, and so obviously, people need to consent to having, the interview recorded before we even, think about applying it. We have it recorded, and then we go through a transcription process with the interviews. And the transcription, there's some pretty robust AI type tools now that can do this, or we've also used transcription services. It's really important that the lines are all numbered and generally down the left column, and that then helps with the scoring and the reporting. And the other thing is that all the non-verbal features or the non-explicit features of the interview should be recorded. So the ums and the ahs and the ahs and whatever other kind of verbiage, that can be really important in making a consideration. And silences should be timed. So you'll often find in these interviews, people will go silent, and sometimes I'll go silent for a minute or more. It's really important that the transcript identifies and details all of that. So what the AAI renders, and the one-day training gives you enough information to make a reasonable assessment of one of the five. As I've said repeatedly, we can't offer help in actually scoring them to the point of, research exactitude, but certainly we get a pretty reasonable understanding of secure attachment, dismissing attachment, which is in the children's literature avoidant, preoccupied attachment, which is anxious avoidant in the children's literature. And then we've got cannot classify, which is a transcript that has qualities both of dismissing and preoccupied organization. So that's why it cannot be classified into one, can't be secure, dismissing, or preoccupied. And the description of that was later developed into a disorganized attachment. Disorganized attachment, from a clinical perspective, commonly and almost universally maps onto a condition like borderline personality disorder. Very, very parallel. And then there's a fifth classification, which is unresolved for trauma or grief. And this is kind of an interesting feature in the transcripts to distinguish between disorganized and the unresolved. And the disorganized has a kind of a quality of a quality of this lack of clarity running throughout, a quality of motility, sometimes dismissing, sometimes preoccupied, almost never secure, and that runs throughout the entirety of the transcript. Whereas unresolved, you'll see this disorganizing feature of mind occur around events and relationships. So the transcript will be moving, it could be secure, it could be dismissing, could be preoccupied, but then the person's asked to talk about, I don't know, a death or a loss, and all of a sudden their thinking starts to become a little more chaotic, a little more distracted, a little bit more incoherent. So you get this sort of partialization that emerges from a transcript for unresolved for trauma and grief. And there are questions specifically within the 20-question protocol that assesses for trauma and grief. So one of the really interesting features of the AAI is the way that it expands out into a greater level of detail. Now, this is linking more to the scoring system, but it's interesting to keep some of these features in mind anyway. When we've got so there are three features of dismissing: DS1, 2, and 3. Five, interestingly, features of security, and three features of preoccupation. Severely dismissing will be generally very short transcripts where emotional kind of presence is really reduced, flattened, not regarded. The respondent doesn't talk in particularly fond terms about relationship at all, often can't remember a lot of detail growing up, will talk about, what a great childhood it was, or what a, loving father or mother they had. But as soon as details are requested, there are none. So you get this sort of quality of idealization typically running through the DS1. DS2 is more devaluing and derogatory dismissing of attachment. I didn't need all that stuff when I was a kid. I was tough. We were built to be tough in those days. We weren't soft like the neighbours. There's this constant kind of putting down of the need for attachment, not necessarily in the way I just mentioned. And then the DS3, and there's a 3A and 3B, which is just a little less severe, but has this sort of constant quality of lack of memory, idealization, but reduction of the emotional needs for attachment. Which then leads us into the secure attachment styles, which interestingly F1 and F2 have dismissing quality. What's different between a securely attached and a dismissing is the degree of valuation, the freshness and reflectivity that people can bring to thinking about difficult situations growing up, and the way that they can move between past and present. So there's a kind of freshness of mind and a clarity that runs through them. Then F3 is a prototypical secure. Um, because we do a lot of work in attachment disturbance. We don't get a lot of people banging on our door to be assessed when they're prototypically secure. So I don't know how many people are out there like that, but I'm sure there are plenty that exist. F4 and 5 is now a movement towards mild preoccupation, um, valuing of attachment, but some confliction around it. But by and large, the person can reflect on the difficulties and challenges whilst returning to a degree of groundedness. Then when we move into the preoccupied styles, there's a very passive style where the transcript is filled with, kind of very, very vague kind of reflections and responses. Sentences break down, lots of intrusive words like "oh yeah" and "but" and da, 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 da. And that was kind of like all that kind of verbiage that really says nothing. There's a preoccupied angry style, E2, where it's different between having difficulty thinking about difficult people in the past and still feeling a degree of charge, to the preoccupied angry. The person collapses into the relationship with the parent they're describing during the interview. So I said to my mother, I was, oh, and you see them getting really angry in just describing the memory. And what they won't have is a capacity to reflect on the fact that they're doing that. It just kind of seems to come and go. The preoccupied fearful type is quite a rare type, but this is a transcript that the person is constantly focused on traumatic experiences, traumatic events. Very similar to the disorganized transcript, but with a slightly more oriented towards just pursuing the relationship. You might want to think in terms of dismissing and preoccupied as hypo and hyper arousal. As we're born with the hypothalamic pituitary adrenal axis active. It's one of the few brain structures that are relatively in place at birth. Much of what we are comes online after birth. But the HPA axis, as you know, is responsible for flight fight, so hyperarousal response, or freeze, hypoarousal. So you might want to think about a dismissing attachment style as one where the child has numbed out. When the attachment needs were not met, the child just flattens, just numbs, just draws on cortisol. There's no choice involved. It's just pure luck, really, I think, in terms of what kind of biochemistry the child's born with, or what experiences that they're having around caregiver, but hypo, and then the preoccupied or hyper. So constantly agitated and trying to kind of constantly reach for attention, reach for connection that's never being fully met. The disorganized, unfortunately, bounces between the hypo and hyper states. So when we take a transcript and we're running the scoring system or the assessment system, we do an initial read through. And then we look at the scales for inferred experience with the parent. So we look at, what's being said, how they're describing the relationship with the parent, and we can mark, features throughout the transcript there. And then we do another read through for scales for patterned or organized states of mind. And then finally, we go through looking for unresolved and disorganized states of mind, and then the adult attachment classification system itself, which is, just a detailed definition of what each of the attachment styles are. So we're really spending quite a bit of time going through the transcript multiple times, looking for different sets of features with each read through. In terms of application, the first questions are designed to engage the subconscious. That's the description of it. So question 1 is really asking to describe what it was like growing up. Then we get to the question about 5 adjectives. So we ask the respondent to offer 5 adjectives about their relationship with their mother when they were 5 years old or thereabouts. Just list 5 adjectives, not that describe her, but describe your relationship with her. Now, someone with a dismissing attachment style will struggle, and so you do a bit of encouragement. And sometimes they get to 5, sometimes, at worst, they can only come up with 3, but we need at least 3. Once we've got those adjectives, we ask then for an event that really, or a situation that really explains that adjective. So we're really looking at how the memory kind of retrieves detail of the emotional engagement, firstly with the mother, and then we do the same thing with the father, 5 adjectives, and then the explication. If there was either a mother or father missing developmentally, left, died, whatever, then we may look if there's a grandparent or someone else that's involved, that's been an attachment figure. We get descriptions of parental behaviour when the child was sick, injured, or distressed. And so we use this information to really shape the clinical application. So when we're using our 3 pillars model, for instance, when we go into the visualization work, we'll ensure that these parents are the opposite adjectives of the memory experience. So, as I said, we apply the AAI in our situation to what we call integrative attachment therapy, IAT, and we work with collaboration, metacognition, and this visualization technique, which is all about the imagination, not about rescripting memory. It's all about imagining how these parents are reacting and responding to this imagined child self. And what we're trying to invoke, and what's absent, one or more of these features is absent in an attachment disturbance. So protecting the infant, attuning to the infant's behaviour and inner state, soothing and reassuring, expressing delight, which is a real kind of invitation, encouragement in the child, and unconditional support and encouragement for exploration. Exploration is strongly linked to dopamine, and problems with dopamine production are implicated in lots of adult problems. Don't think everything comes simply from the brain or from brain circuitry or neurochemistry, but there's a strong interaction between mental consciousness and the brain itself. So just give some time now if people have got any questions for me about this, about the AAI. We've got another online one-day workshop. If you'd like, we'll send these slides out to participants in this call, and if you're interested, and feel free to get in touch with us here in Melbourne, but we've got people working all over the place.